So look, my role here tonight, other than sort of just make sure it all rolls, is to just give a brief update on what we're doing in our comprehensive voice assessment clinic at the university through the Dr. Lang Voice program, and just a little bit of a review of how we're coping in a private practice setting. I'm very lucky to, as well as working at the university, run a private practice. So look, very quickly, I'll just review the limitations that have already been spoken about, talk about the recommendations by our peak body, Speech Pathology Australia, talk about what we've been experiencing in terms of community expectations during this time, what we might consider as opportunities. It's been a very dark time, but there might be some silver linings for us to think about, how we've been trying to manage the transition from the old world to the new, and what we're doing in our current practice. So Dan's already talked at great length about the recommendations for ENT practice around minimising exposure to aerosol generating procedures, so I won't dwell on that at all. This is the statement from the Australian Speech Pathology Association on aerosol generating procedures, and they are completely in step with the ENT recommendations. So there are clearly some things now that we just cannot do in the current circumstances, but it is interesting, as we've discussed this, that there's been a side conversation, certainly in Australian circles, but I do know internationally, when we ask the question, is speech-language pathology considered an essential service? I'm aware of some conversations in the States where Dr. Lucian Salika was very, very adamant that speech pathologists are now invaluable and essential in managing our laryngology patients because of our role now in monitoring in the absence of being able to scope. So at our University of Sydney Comprehensive Voice Assessment Clinic, we run a student-involved interdisciplinary clinic. This takes a very, very large and comprehensive range of measurements to provide best practice in assessment of voice disorders, because obviously we do laryngoscopy and airflow measurements, which are high risk aerosol generating procedures. We're not running the clinic currently, but we are looking to now develop a telehealth model for student training in second semester, so we may be able to resume some form of service using this model that Chris has talked to you about tonight. But of course we're going to need some sort of training around that, both as staff and students, and obviously university approval. So when we think about the COVID curve, and haven't we all been thinking about the COVID curve and keeping an eye on it, we've been wanting to flatten it. But I think what's been happening in all of our lives is we've been on another rampant curve, just trying to cope from day to day. The amount of change in our clinical practice cannot be underestimated, and my colleague Tricia, who's going to follow, said some very profound things to us over the last few weeks about how we really have, in so many ways, become novices in the things that we're used to being expert at, and that's very challenging. Now, our Speech Pathology Association in Australia has made some very clear guidelines for us to follow around triaging our speech pathology clients, and this is the official document. You can see from the new referral and request to review, and these, of course, these recommendations are all available on the Dr. Lang Voice program, the DLVP.org website for you to review or download. It clearly indicates the risks: aspiration, choking, reduced communication need leading to social and emotional isolation, inability to activate an emergency response, etc., and risk of malnutrition, dehydration. Now, from a private practitioner's point of view, this has, from my point of view certainly, a much more of a hospital-based clientele focus, because of course in our practice we see mostly people with voice disorders and upper airway disorders. In any case, we interpret it in the spirit it's meant, and we make a decision about whether we will move to a telepractice intervention or assessment as in the first instance, or consider a face-to-face intervention. Now, the assessment of a face-to-face, whether or not we will see somebody face-to-face, we take into consideration in our practice the risk tolerance of our clinicians. There are people in our practice who are more at risk than others, so that must be factored in. But we do follow these standard guidelines in terms of identifying people as COVID negative or suspected or COVID positive. So that's our broad overarching sort of approach. In terms of our interaction with the community very early on in this crisis, we've been very much heartened by how our patients have responded to this evolving crisis. Their responses have been varied. Some are completely expecting telehealth and very compliant and just happy to go with the flow. Others are expecting business as usual and only want a face-to-face consultation, and if they can't have it, they'll wait, regardless of sometimes their presentation. Occasionally we have difficulty with resistance to technology, either using the use of the web platform or getting a microphone, or not wanting to sometimes use an iPad or even a phone. We're finding collecting verified information and consent much more difficult than we used to, because they used to just come in and fill out paperwork. So finding adequate and secure online options is not easy. But that said, most of our patients are very understanding and very grateful. And you know, my receptionists have said that, you know, not a day usually goes past where a patient doesn't actually send an email or verbally just say, look, thank you so much, I really appreciate all that you're doing. And that's very heartening at a time of great change. So in terms of all the flux and change, what are our opportunities? Well, it's quite clear now that telehealth has arrived because we have to. And now, certainly in Australia, it's moved to the same status as face-to-face billing from both a Medicare and a private health insurance point of view. And that's definitely a great silver lining. Speech pathology has been developing telehealth models of care for many, many years and had sort of a number of battles to get that recognised. So that's been a great step forward. This crisis really allows us to look very closely at a first contact model. And we're very fortunate that the work of Paul Carding, Marnie Seabrook and now Chris Payton has really developed this model to the point that it can be adapted so quickly and easily to a telehealth model, literally in a matter of weeks. Chris has been working on his PhD now for a good year and working with this model for many years. So we've been able to adapt it to include the recommendations of the local peak bodies, which is very exciting. What the model also does is really recognise the expertise of allied health practitioners and speech pathologists. You know, we've been tracking patients, we've been making provisional diagnostic classifications of our patients in conjunction with our ENTs for many years. So it's really, this is our opportunity to really consolidate and recognise that expertise. And I hope, you know, in the long term, that will ultimately allow us to reduce waiting lists for our patients and provide a much more streamlined service. Obviously, we've all had to adapt to a much more flexible service delivery as the needs of the health officials and our patients change. And I think it's also given us a need to really think about what is absolutely essential for us to do. You know, we can often find ourselves doing things because that's what everybody else does, or that's what we got taught. But really, we need to think very seriously about what is essential to do for best care, so we're not wasting time and we're not putting ourselves in situations where we don't necessarily need to be. So how has my practice transitioned from the old world to the new? Well, we've provided telehealth services nationally and internationally for the last 10 years. It's not been a great percentage of our practice. It's probably been about 10 to 15%. Because it's only been that small, we've actually managed relatively well to collect high quality data for a process of a lot of patient education, product knowledge, so we can suggest to patients which products they can use for better sound quality and ease of use, and lots of encouragement that using the technology is important and helpful to their rehabilitation. Obviously, our services were improved with the arrival of good internet services in Australia. And we also, 3 years ago, developed some online data collection and patient support resources that we now use regularly in the practice to track people's progress. What this current crisis does, though, and we've always thought in the practice that there was a great need to collect a lot of data and high quality data so that we could really understand, you know, the nature of our patients' recovery. But what this crisis does now is tell us that high quality, consistent, comparable, and frequently collected data is now imperative in our speech-language pathology model if we can't scope patients, because our patient-reported outcome measures, our auditory perceptual judgments, our acoustic analysis of those auditory perceptual recordings, of those auditory recordings if quality allows, our assessment of functional tasks, that's all now really invaluable data to inform provisional diagnosis to discuss with our ENT colleagues and to track patients' progress so we know, are they getting better, are they staying the same, or are they in fact getting worse? So when we look at what data we can collect, and Dan's talked about specific patient-reported outcome measures in terms of airway, there's a big range, and Chris has mentioned them in his model. But making sure you collect relevant patient-reported outcome measures is imperative. There are so many that we can use. So actually making sure that we choose ones that are relevant to the patient, where we know important cutoff values that we can compare to normative normative populations, is all going to help us interpret those patient-reported outcome measures in a more meaningful way and help us understand what the patient may or may not need. Getting high-quality audio recordings is always important, but of course it's the hardest of the data to collect because of the variable quality of recording across devices. Mobile phones, yes, they've come a long way, but they all use different compression rates, sampling rates, which means that comparing auditory perceptual judgments and acoustic analysis across devices is near impossible. Doing a comprehensive functional assessment, which really tests what the voice can do across a range of different tasks and can be tracked over time, we've found very, very useful. Making sure that you use consistent and standardised measurement protocols. So collecting the data in exactly the same way, using the same instructions, using the same measurement tool is terribly important for comparison. And we've also done a lot of clinician training and fidelity checking of people's assessment protocols, whether that be in an initial assessment or across a standardised baseline that we collect in every session. So how we've had to adapt that now, because of course we're constantly having to adapt as we get new recommendations and we find out more about this virus and more about our risk factors. We are using now more and more, we're sort of trying to embrace this telehealth first contact model as fast as we can, and following the Speech Pathology Australia recommendations. We're updating our consent and security procedures based on different avenues of advice, peak bodies, etc. We do 2 pre-consultation triage contacts, which whilst is very time consuming for our reception team and sometimes our clinicians, we feel that it's the best risk management. So when people ring to book, we ask them a range of questions, as you can see below. And if they answer yes to any of them, they then get passed on to a clinician who phones them and discusses their risk factors. If they're considered to be at risk, we then go straight to a telehealth model and we don't see them face to face. If they say no and they're under 60 to all of those questions, we then look at considering a very short face-to-face interaction purely for the collection of high quality data. Now, all of our upper airway patients are seen only by telehealth. For the patients that we consider to be very low risk, we will book them in for a 15-minute data collection using our equipment. And this is for initial assessment. And then if we think they need review, as in they're not progressing, if we think they've become at risk and they may need referral to the ENT, we'll book them in again for as long as they are still passing all of our risk assessment protocols, because we need to know whether or not these patients do need to be categorised as being more urgent. So our telehealth service delivery, we use usually Zoom, some patients like FaceTime and some WhatsApp, but we do really adapt to the patient. We just make sure we use the same device across a patient. So we don't want to swap devices because we do have a recording protocol where we get the patient to record themselves and upload it, and then we can listen back to it and analyse it. We support the patients to attain their best recordings between any face-to-face reviews, if just in case we don't get another face-to-face review. We standardise our data collection across all sessions, and we chart the data to analyse progress. So we're currently increasing our use and we're currently developing more customised online resources to streamline and help our practice. We continue to review our service delivery model to be more agile and responsive to patient needs. And also our ENT colleagues, we've sort of staying in very close touch with them as they start to sort of find their way as well. We're in this together and we need to work together to really meet the needs of our patients as the situation evolves and change. So ideally, we're sort of thinking about some sort of fully remote solution eventually, but we've still got a lot of work to do. So I've had many patients say to me, it'll be great when it's over. We don't know when it's going to be over, but in the meantime, we're all in it together, and I hope what I've talked to you about today has been of some value. Thank you very much.